presentation, we have Austin Morial, Community Engagement Coordinator and NJ Interfaith Center for Cancer Care in Highland Park, New Jersey, and our very own Kyle Jackham, Oncology Social Worker and our Social Work Manager at Crossroads for Hope. They will present on the topic Identity Development and Life Milestones for AYAs with Cancer, and explore the intersection of cancer care and the unique life challenges faced by adolescents and young adults, with a particular focus on the LGBTQ plus needs. Kyle and Austin come to this work with a background in oncology, both personally and professionally, and will delve into the complex life changes faced by youth and young adults, like navigating medical treatments, emotional shifts, and social adjustments, and how all of these factors intertwine with the ongoing formation of personal identity with the AYA community. My pleasure to present Kyle and Austin.
All right, this is both exciting and terrifying, but I'm here and I'm so happy. I do want to just preface, I was in an accident earlier this week and I'm not completely feeling 100%, but I am so happy to be here and really just want to thank you all for joining us at this year's annual Conference on Cancer. Like Catherine had said, my name is Kyle Jackham. I am the Social Work Manager as well as an Oncology Social Worker at Crossroads for Hope. I'm joined by Austin Morial, who I want to give a chance to introduce himself as well.
Hi, everybody. I'm Austin Morial, and I work for a very small community-based nonprofit program located in Highland Park called the New Jersey Interfaith Center for Cancer Care, which sounds like we're a huge facility, but we're a very small program just located across the river.
And we want to welcome you to our presentation, From Patient to Person, Identity Development and Life Milestones for AYAs with Cancer. By the end of today's presentation, Austin and I hope that you gain insight into the AYA cancer community by understanding the common cancers within this community, as well as emerging trends. Help understand how cancer can disrupt life milestones and really understand a deeper understanding of the LGBTQ plus community and the unique challenges that they face. Discover ways through available resources that are very much particular to this age group, and then overall to essentially increase your sensitivity and understanding to help foster empathy and compassion as you approach AYAs in your professional work or personal work or life. And I really want to start by sharing my story. My story begins in 2010. At the very beginning of 2010, I came out of the closet as gay. And in the summer of 2010, I was diagnosed with cancer. I like to start by really sharing my story as it was one summer night after a brand new episode of Pretty Little Liars aired. And it was a good episode, I would have to say. But after that, I started to feel my left side of my face become numb. From there, I went to the nearby hospital. They chalked it up to an ear infection. And a couple days progressed. My left eye started to just not really operate in the best way. My blinking started to slow. My contacts started to fall out. And then another day or two later, my mouth started to droop. All of these were red flags that brought me to Robert Wood Johnson in New Brunswick. And after scan after scan after scan, blood works, a lumbar puncture that was not under anesthesia, which was extremely uncomfortable, bone marrow biopsy, as well as a lymph node biopsy. And after an x-ray that showed that I had a tumor the size of an orange right next to my heart. And I was diagnosed with T-cell lymphoma cancer at the age of 16. At that point, when I was told I had cancer, I didn't really know what cancer was, I'll be honest. I thought it was just another cold that I was able to get over. I was 16. I was not really knowledgeable about what cancer really was. and essentially I went through 2 years of chemotherapy and radiation. I lost my hair, and essentially there was a lot of the transitions and milestones I can definitely relate to that I'll be talking about, specifically for the adolescent age. Through that, I had a lot of support. One being my mom. My mom was my absolute rock. And then there were specific moments where I was very nervous, just being an adolescent going through this and understanding that I might not be able to graduate on time. I might not be able to go to prom. Is anybody going to ask me to prom? I have no hair. I have moon face, and I was just very nervous about my own just self-confidence, self-esteem, and how I looked, especially in high school. Fast forward to 2020, that photo right there is actually the very first day that I started at Crossroads for Hope. It was in the middle of the pandemic, and that was my very first job as a social worker. I am now been at Crossroads for Hope for 5 years, and fast forward to 2022, where I traveled to 3 different countries in one trip to celebrate 10 years cancer-free. And this summer, in July of this year, I will be celebrating 13 years cancer-free. The term adolescents and young adults generally refers to the individuals aged 15 to 39. However, some institutions and studies do define it as 15 to 29. Let's look at the most common cancers breaking down by each age group. So we have the 15 to 19-year-olds, and these are some of the most common cancers within that age group, 20 to 29, and then 30 to 39. So there's good news and concerning trends in the AYA cancer research. So the good news is that death rates are declining about 1% per year since 2013. The concerning trend is that we are seeing an increase of about 1 to 2% each year, and that was between the years of 1995 and 2020. Specifically, the cancers of breast cancer, prostate cancer, cervical cancer, endometrial cancer, and colorectal cancer. These are often referred to as early onset cancers, which is cancers that are diagnosed in adults between the ages of 18 and 49. And why is it called early onset is because while cancer is not uncommon before the age of 50, at the age of 50, cell damage does begin to build up in the body and the rate of cancer incidence climbs. And one challenge is that many adolescents and young adults are too young for the recommended screenings. As you can see, colonoscopies start at the age of 45, whereas mammographies typically start at the age of 40. So one aspect and insight, I think, is definitely to try our hardest to have early screenings programs as part of this age group. Survival rates for adolescents and young adults have improved, but there are long-term side effects that still remain a significant concern. One of them being fertility issues. The next being an increased risk of secondary types of cancers. Another being cardiovascular and immunological conditions and infections, hormonal imbalances, and then one of my favorite topics to talk about, because I have this in the back of my head, is fear of recurrence and mental health struggles. So I want to really focus on the key life milestones and transitions that are typically disrupted by cancer. Everyone in this room has either experienced one or all of these milestones and transitions that I'm going to be talking about. I wanted to focus on 4 different areas: education and career, social relationships, independence, and identity exploration. And in a way to really be able to share and to really have everyone in this room put themselves in the shoes, you're going to see these storybook icons on some of the slides moving forward. And these are really going to be guided reflections on trying my best to put yourself in the shoes of someone that is diagnosed at a specific milestone and or age. So for the first one, I really wanted to use education and career as one of them. Imagine you are a college student, miles away from home, immersed in the life you've built, late night study sessions, spontaneous adventures with friends, the anticipation of your future unfolding. Then, in the sterile quiet of a doctor's office, everything changes. A diagnosis, cancer. The weight of those words presses into your chest. Suddenly, your plans shift. You pack up your dorm, say goodbye to the independence you worked so hard for, and return home. Not for a break this time, but for treatment. Your friends continue, their lives moving forward, celebrating milestones that were supposed to be yours too. You cheer them on from afar, but inside, you wrestle with the reality of your own timeline now put on hold. Take a deep breath. How do you navigate this? What does resilience look like when the path you planned is no longer yours to walk, at least not right now? How do you hold space for both grief and hope? As you can see, this is an example of an education plan. Cancer disrupts education and career plans, making it difficult for adolescents and young adults. Work and education, they provide identity, income, and most importantly, health insurance. We all know that at 26, we lose our parents' health insurance, no matter how good that was. And we have to find a job or go through insurance on our own in some sort of way to pay for that. In addition, it impacts our social relationships with our peers, as well as just our ability to just obtain a degree, essentially. I want to move towards the loss of independence and the developmental impact that cancer can really have. Adolescents and young adults are at a stage where they're building independence, they're starting careers, they're forming relationships, and they're discovering who they are. A cancer diagnosis can abruptly halt this. They have delayed milestones and life transitions that they might have been looking forward to. They have identity and self-esteem challenges. I was a college student, and now I'm a cancer patient. Who am I? They are wondering, am I going to graduate with my peers? They have emotional and psychological consequences, anxiety, depression, reliance on family again. They might have chosen a college that was so far away from their hometown because they wanted to get away from everybody, and now they're back. They have to rely on family again because they don't really have anybody out there because they just started college. Impact on decision-making and family and future planning. I'll go over in a couple slides family building and family planning, and I know that Matt Zachary really, I think, set us up for success in this presentation because he did highlight some of those transitions that he himself experienced. So the next milestone that I really wanted to focus on was social relationships. Adolescents and young adults are at a pivotal stage in social and identity development. In fact, unmarried adolescents and young adult survivors have higher levels of distress and depression than their married peers. As you can see in the yellow, that 1 in 3 adolescents and young adult cancer survivors have a risk of psychological distress and or anxiety, and 1 in 4 have a risk of depression. We know that mental health and isolation, as well as just depression, is very prominent in this age group. And I think that just ensuring that mental health resources are available and part of the survivorship plan is one of the key. Social relationships. As you can tell, disruptions in peer relationships, challenges in romantic and intimate relationships, and then challenges in parenting. Disruptions in peer relationships. We can all probably relate to every single one of those events on the screen: prom, high school graduation, college graduation, attending sporting events, and school activities. I know when I was getting treated, I typically would hate being in the hospital. was scared to get a fever because I knew what that meant. If I got a fever, I would have to be in the hospital for a week, or until the fever broke. And I would see social media, all of my friends being at sporting events, and I was sitting in the hospital room having my IV in and getting treatment. And it was the worst feeling of FOMO that I've ever experienced. And that stuck with me. There were rumors going on in my school that I was not going to graduate on time, because I think for my junior year, I was probably in school for about 90 days out of the entire year. The rest of the time, I was either at home dealing with side effects, or I was in the hospital still getting schooling. But there were a lot of impacts there that fell into challenges in romantic and intimate relationships. Just coming out of the closet earlier that year, there were me trying to explore my identity and my sexual orientation, and that was also very difficult. I had moon face, I had no hair. There were a lot of guys that I was trying to talk to that didn't want to have anything part of me, because unfortunately in this community, that looks matter, especially in high school. So that also played a significant role in just my own self-esteem. Challenges in romantic and intimate relationships are also just about dating. How do you talk about long-term health, fertility, and income security? How do you talk about how I might not be able to have kids on your first or second date when the other person is trying to say that I'm looking forward to building a family one day? It's a hard conversation to have. Challenges in parenting. I'm going to go to the next guided reflection. And I'm sure anyone in this room that have kids can kind of understand to a degree of what this can look like. I thought I had time to watch them grow, to be there for the big moments, the scraped knees, the first days of school, the late night talks, time to shape the kind of parent I wanted to be, but now cancer. And suddenly, time feels like I can't count on. I tuck them in at night, watching the way their small hands clutch their favorite toy, the way they whisper, "I love you," before their eyes close. And I wonder, will they remember this? Will they remember me? Not just the version of me that's sick, but the one who made them laugh, who held them when they cried, who loved them more than anything. I don't want them to grow up without me. I don't want them to forget the sound of my voice, the way I looked at them with nothing but love. I want to leave something behind, not just pictures, not just stories, but something real. But how do I do that when I'm still here trying to hold on? Take a deep breath. How do I prepare them for a future without me while still hoping I'd be here? How do I make peace with the fact that I might not see who they become? And how do I make sure that no matter what happens, they will always know how much I love them? Fertility is a top concern for adolescents, cancer survivors, yet, as you can tell, fertility preservation and family planning, the cost is absolutely wild. At the same time as just the conversation itself. I think having counseling before having this conversation is important. A lot of health insurance companies do not pay for fertility preservation. However, I did learn through my own research that each state has mandates in regards to basically insurance that some cover certain coverage of fertility preservation. However, it's not typically the entire thing. So some might cover a couple IVF treatments, some might cover just the surgery, not the follow-up care, not the medication. There's a lot of financial concern involved with fertility preservation and family building. I'm going to go to my next one, and this is very much related to my own experience at 16, being asked if I wanted to basically have a family one day, and my own experience with needing to determine at 16 if I needed to freeze my sperm. I'm still figuring out who I am, what I want, who I might become. I don't even know where I'm going to college next year, let alone if I want kids someday. And yet here I am, sitting in this doctor's office with my parents, being told I have to decide. Fertility preservation. A choice I never thought I'd have to make, a choice I don't feel ready for. They're asking me to think about a future version of myself that feels so far away, one where I might want kids or might not. But how am I supposed to know that now at 16? It feels unfair, like cancer is taking something from me before I even got to consider if I wanted it. If I say no, will I regret it later? If I say yes, what if it never even matters? And then there's the cost. Not just the emotional weight of this decision, but the actual price that my parents would be paying for, and then me. Thousands of dollars for a future I'm not even sure I want, for something that may not even work. Take a deep breath. How do I make a decision for a future I can't picture yet? How do I know what's right when I don't even know who I'll be or who I'll be with? And how do I carry the weight of a choice I never should have had to make in the first place, one that might follow me for years in ways I can't even yet understand? I know that there is a presentation during one of the breakout sessions that will be focused on caregiving in the AYA community, but I still felt it was important to highlight briefly. I am the facilitator of our caregiver support group at Crossroads for Hope, and I work with caregivers, and it's honestly become one of my favorite populations to work with. One being, I was finally able to see what my mom was going through. I always saw my experience in the eyes of just being the patient, because that's what my experience was like. But after working with caregivers, hearing their side, I finally understood what my mom was going through and how terrified she must have been. Caregiving in the adolescents and young adults community is even more difficult, I would say, because of that identity and independence. But essentially, it's really the shift from partner to caregiver. You're starting a brand new relationship, and then you're smacked with a cancer diagnosis, and then you are going from boyfriend, girlfriend, boyfriends to patient and caregiver. And while that you might try to keep that romantic and intimate relationship going, it's still difficult. The patient's going to feel the physical side effects, and then the emotional, and then you have the caregiver who is watching someone that they love, someone that they were expecting to have a family with and a future with, now potentially have their life in jeopardy. The emotional impact and peer isolation. During this time, it's all about making friends. It's about networking. It's about really trying to just become your own self in these years. And there is usually guilt and frustration as the independence in the relationship shifts. And then there's the financial and practical concerns. You have the financial, where if you are married in this, you go from a dual income household to a single income household. You might have a brand new newborn in the family, and now you're wondering how I'm going to be paying for groceries, for childcare, and all of these other questions and concerns that come up. A 2014 study found that young adult cancer survivors frequently experience changes in intimacy and self-image due to scars, surgeries, painful intercourse, difficulty achieving orgasm or ejaculation, weight gain, and hormonal fluctuations. Who here, I want everybody to raise their hand if you've had your first date and you were very concerned about how you looked before you went on your first date. Raise your hand. All right, almost everybody here, and everybody that didn't raise their hand, I'm sure you're most likely lying, but that's okay. Everybody, I feel, has some anxiety and anxious feelings when it comes down to just you're about to meet someone that could be your future. You're excited. You're also nervous about how you look. That it's common. But now put yourself in the shoes of someone who had surgery, a double mastectomy, had both of their breasts removed, might be entering with their hair still trying to grow back. as well as just the hormonal and fluctuations that come with treatment. There's a lot of side effects that I feel are difficult to talk about on those dates, as well as having your significant other kind of understand. And that plays a role in just the intimate part of a relationship. And finally, in my area is identity exploration. Identity disruption and reconstruction is one aspect that I touched on briefly, which was I was a college student, now I'm a cancer patient. Who am I? You're balancing normalcy and survivorship. That new normal that a lot of us talk about after you finish treatment, it's difficult. You don't have the energy. You don't have the same, I would say, you don't feel like yourself going back to work, going back to college after you dropped out because you had to go through cancer treatment. You don't know if you're going to be able to have the same amount of energy or fatigue feeling that you've been experiencing, not being able to do full work day. A lot of that is identity as well. You're seeing a lot of your peers go through their first job and you're still feeling stuck. You're feeling left behind. Those past aspirations and new realities. I wanted to be a star athlete. And now with cancer, I had either my leg amputated or due to the treatment that I received, I'm now not able to pursue the dream that I once had of becoming a star athlete. And now needing to find a new reality after treatment. It also, identity exploration, is impacted when it comes down to the LGBTQ+ community with just the gender exploration, with the coming out journeys, as well as navigating a healthcare institution system, I should say, that discriminates against the LGBTQ+ community. And I feel like a better way for all of us to have a deeper understanding is to really just learn more about this community and the unique challenges that this community faces. And I'm going to hand that over to my co-presenter, Austin. Thank you.
Hello, everybody. Thank you for coming out on this beautiful spring day. Again, my name is Austin Morial, and I am with the New Jersey Interfaith Center for Cancer Care. The New Jersey Interfaith Center for Cancer Care is just one of the 3 nonprofits I work for. In addition to working for 3 nonprofits, I'm a husband, a stepfather, a brother, a son, a grad student, a poet, a rookie metal detectorist, a former soccer player, a former advertising copywriter, but not at BBDO, Ogilvy and Mather. A former dog daycare manager who is still obsessed with dogs. And I just happen to be a transgender man. This is a little bit of my story in photographic form. You can see, there have been a few changes over the past 54 years. One picture I'd like to especially draw attention to is the May 2010 picture. I had just, I'll fill you all in on the cancer story in a second, but I had just completed, or I had chosen to stop, I should say, my radiation treatment. And my then girlfriend, now wife, who is not in that picture, and her 2 kids had flown down from New Jersey. I was living in Atlanta. My friend Carrie had thrown a stopping radiation party for me. And my wife absolutely hates this picture. There's also a picture of her and me from the same party, which I thought was a great picture, but she will not look at it. She won't frame it. She doesn't want to look at any of these pictures because she says when she looks at that, she just sees me as sick. I look at that picture and I think, thank God I'm alive. And then in August 2010, 3 months after I had stopped radiation, I moved up here to New Jersey. So my story starts in Atlanta. I lived in Atlanta from 1994 to 2016. And I came out as gay in about 1994 with very little fanfare. and then came out as transgender in 2008. Then in 2009, I started taking testosterone. I had my top surgery, which is a double mastectomy. I had it scheduled. I had raised funds to have the surgery. I was getting my blood work done at a local community clinic where I was also receiving the testosterone. And prior to my getting on testosterone, I was having some problems. I'm going to share. Why not? We're all friends here. I was having irregular bleeding and bizarre periods and bizarre cramps. I also happened to be uninsured, so nobody was really too interested in doing too much investigation. But luckily, this little community clinic in Atlanta, besides putting me on testosterone, they also followed up very diligently with blood work and were able to notice that there was something very wrong with my blood counts. On the Sunday of MLK Day weekend in 2010, I woke up and could not see out of my right eye. And I thought, this is not good. That plus the fact that for months I had been having trouble bleeding, I'd been fatiguing easily. I finally went into the emergency room that morning. Being uninsured, I went to the hospital in Atlanta. If anybody is familiar with Atlanta, Evelyn, are you familiar? Okay. I went to Grady Memorial Hospital, and if I don't know if things have changed, but in 2010, if you were in Atlanta, you did not want to go to Grady. It was known as the indigent hospital. It was a public hospital, but as I wasn't indigent, but I sure as heck was uninsured, I went to Grady. And after, I think I was hospitalized for about 10 days that time, and then several weeks later, I was finally diagnosed with aplastic anemia. If you're not familiar with aplastic anemia, it's a pretty rare blood condition that occurs when something damages your bone marrow so it can't make new blood cells and platelets. On that day that I went into the emergency room, my platelets were at 14,000, and the average normal range is 140 to 400,000. So that just gives you an idea of how serious things were. So the treatment for aplastic anemia, I wasn't qualified. I couldn't qualify for a bone marrow transplant because of the amount of blood transfusions I'd gotten. Was going to be a 3-month hospitalization where I would basically be filled with, can't remember if it was rabbit or horse. It was either enzymes or amino acids. They're basically going to break me down and rebuild me better than before. The night I checked into the hospital for that treatment, I accidentally found out that I had cancer. Cancer was not on my radar in March of 2010, but a med student had come in to tell me that we'd be starting the aplastic anemia treatment the next day, and then he just offhand said, "Oh, and while you're here, be sure you talk to your OB surgeon or your OBGYN because I looked at the results from that last test you had, and I saw that it was cancer." My face dropped. The student left. So that was my introduction to my world, my personal cancer. A couple days later, I had a complete hysterectomy, and then I just sat in the hospital because nobody knew what to do with me. They had never, at their hospital, and apparently in any hospital they could find, had a patient that had aplastic anemia plus cancer. They couldn't treat me for the aplastic anemia because that would make the cancer worse. They couldn't treat me for the cancer because that would make the aplastic anemia worse. So one day, and I'll refer to this pair of doctors as the angels of death, they came flying into my room. It was about 5 o'clock in the afternoon, and they said, "Austin, you can't do the standard regimen of chemo followed by radiation. Chemo will extend your life, but with the aplastic anemia, it will make you so sick that you will not want to be alive, basically. You will be so miserable. Radiation, you will have a shorter life, but it will be a better quality of life because you won't be as sick. So you need to choose between length of life or quality of life, and we'll be back at 8 a.m. tomorrow morning for your decision." And they left. I cried. Luckily, I had a great hematologist who advised me how to proceed, and a wonderful radiation oncologist who ended up developing a rather unorthodox radiation plan. Because I had stage 3C uterine cancer, and so the radiation treatment for that would normally be focused at my pelvic bone. However, since the pelvic bone is the factory of the blood cells, they didn't want to. They did not want to aim the radiation there. So instead, they aimed it at my intestines, basically. And as a longtime IBS sufferer, that was the last thing I wanted to hear. It was like, no, please. But we got through it. And a couple days before my 39th birthday, the radiation oncologist said, okay, Austin, if you're going to look at all this data, you've got about 6 years to live if you're going by the data. Well, that was a few days before my 39th birthday, and I just celebrated my 54th birthday on Wednesday. So I beat the numbers. And with my radiation oncologist, and I was supposed to be moving up to New Jersey the end of that summer to be with my girlfriend, now wife. And once my radiation oncologist reminded me, Austin, they have doctors in New Jersey. It's like, oh, okay. So I was hesitant to leave, and my hematologist told me, I said, Doc, are my blood counts good enough? Can I leave? And he said, Austin, I don't treat numbers. I treat people. Get out of here. And so here I am. And then in 2014, I happened to be diagnosed with a second diagnosis, completely unrelated to the uterine cancer of sebaceous carcinoma on my eyelid. Based upon my cancer diagnoses, my mother's history of cancer, she passed away from cancer in 1995, and the cancer in her family, I couldn't afford the genetic testing, but my doctor said, I think it's fairly safe to say, based upon this history, based upon a dermatological condition you have, you more than likely have Muir-Torre syndrome, which is a genetic syndrome that makes me more likely than the average Joe to get cancer, certain types of cancer. So basically, I just need to be a little bit more vigilant and have, unfortunately, colonoscopies once a year. So that's a little bit of my background. I am not a doctor, as you can probably tell. I'm not even a social worker. And throughout my presentation, there will be data, there will be research, and there will be science, but there's also going to be personal insight and reflection based upon my experience navigating the medical field as a member of the LGBTQ community, and obviously having friends in the community. And whenever I speak, I'm just speaking for myself. I don't dare claim to be speaking for the entire LGBTQ community, nor do I dare to speak for all the trans men in the world. It's purely my experience and my opinions. So why are we talking about the LGBTQ plus community following on the heels of Kyle's first part of the presentation? Well, in 2021, 7% of the adults in the United States identified as LGBTQ+. And 21% of Generation Z, born 1997 through early 2010s, identified as members of the community. So the younger the folks are these days, there's a greater percentage identifying as part of the community. And these words are probably all very familiar with everybody, but just to make sure we're all on the same page and speaking from the same space, just go over some quick definitions. Lesbian, a woman who is emotionally, romantically, and or physically attracted to other women. Gay, it describes people who are emotionally, romantically, and or physically attracted to people of the same gender. Usually refers to men, but some women also like to use the word gay. For instance, before I transitioned, I did not like the word lesbian, so I used the word gay. Bisexual, commonly known as bi, a person who acknowledges in themselves the potential to be attracted romantically, emotionally, and or sexually to people of more than one gender, but not necessarily at the same time, in the same way, or to the same degree. Then the T is for transgender, often shortened to trans, describes a person's gender identity that doesn't necessarily match their assigned sex at birth. Trans individuals may or may not decide to take hormones and may or may not decide to have surgery to affirm their gender identity. Then the Q is for queer, a term that some members of the LGBTQ plus community use to describe themselves and their community. Reclaimed from its earlier use, queer is considered by some to be more inclusive and to include folks that are left out of the alphabet soup. However, some members do not like to use the word queer as it harkens back to the time when it was used as a slur or pejorative term. I myself like the word queer because it rolls off the tongue easier than LGBTQ+. And I also think it more accurately describes me. So I might hop back and forth with the different community labels. And under the plus, you've got some examples of plus listed and defined up here. Non-binary, people who don't describe to the gender binary of male and female. Pansexual, a person whose emotional, romantic, and or physical attraction is people of all genders. Asexual, sometimes known as ace, an individual who does not experience sexual attraction. And then they're not part of the alphabet soup, they're not part of the community, but it's such an important word, ally. An ally is someone who supports LGBTQ plus individuals and the community. And even though allies aren't part of the community, the queer community needs active vocal allies, whether we're talking about healthcare, whether we're talking about social justice issues, politics, whatever. The queer community cannot fight our fights by ourselves. So sometimes people get confused with sexual orientation and gender. Sexual orientation is simply the sexual attraction towards other people or maybe towards no people. And while sexual activity involves the choices one makes regarding behavior, one's sexual orientation isn't defined by one's sexual activity. And gender, in general terms, is a set of socially constructed roles, behaviors, activities, and attributes that a given society considers appropriate related to a person's assigned sex. And cisgender or cis is an individual whose gender identity aligns with the sex they were assigned at birth. Now we're moving into the cancer stuff. So you'll see on this slide that the TQ plus has been left off. It's not because I have erased us. It's because this particular slide is focusing solely on sexual orientation, not gender. The T will be on the next chart. The problem with this sort of data is that precise medical data on the queer community is not readily available. It's very difficult to compile. Sexual orientation and gender identity aren't consistently collected in medical records. And even if your doctor or doctor does ask, the patient might be hesitant to be truly forthcoming for a variety of reasons. While this chart shows that the percentages among LGB members of the queer community are mostly similar to those of their heterosexual peers, I, again, not being a doctor or even anything related to the medical field, I, based upon lived experience, would like to put forth the proposition that the numbers for the queer community are probably much higher, based upon the fact that the identity isn't recorded on medical records, and also the hesitancy to come forth with their true either gender or their sexual orientation. Cancer in the trans and non-binary communities. And again, this is just focused on gender, so the L, G, and B are not on here because it's gender, not sexuality or sexual orientation. One thing of note, or that I found interesting on this graph, is that trans men have the lowest prevalence of female breast cancer, cervical cancer, and colorectal cancer. And why? Is it because that we as trans men are less likely to go to the doctor because we feel disconnected from our chests, our breasts, and our cervixes? Some might make the argument that the prevalence of breast cancer is lower among trans men because the chances of developing breast cancer are significantly lowered if a trans man has top surgery. But according to the National Institute of Health, only roughly 50% of trans men have top surgery. Not all trans men have the economic privilege to get top surgery, and not all trans men want to have top surgery. And I think that this is just a good example of reminding the healthcare community that they need to remember that everybody, or there's not a one-size-fits-all. There's no cookie-cutter approach to treating the LGBTQ community, just as there's no cookie-cutter approach to treating any community. So next thing I'd like to talk about is factors that can contribute to why members of the queer community may have a higher chance of, or an elevated cancer risk. And I tick the box for every one of these factors, and they include, but are in no way limited to, behaviors, lack of equitable care, and fear of discrimination by healthcare providers. All three of these factors could have come into play with my diagnosis, or given the history of cancer on my mom's side of the family, they very well could have at least contributed to my diagnosis at a younger than average age. I was diagnosed with, as I mentioned, stage 3C uterine cancer at 38. That's a cancer that normally the average diagnosis is made in women who are age 60. And according to the American Cancer Society, it's, quote, uncommon in women under the age of 45. So one of the behaviors that is prevalent, especially among the queer community, is cigarette smoking. And I think we all know cigarette smoking is not a good thing to do. It increases the risk of at least 12 types of cancers, including 25 times risk of lung cancer. It's also the most preventable cause of cancer occurrence and death. You can read the percentages there for yourself. One that I do want to highlight in particular, or three that I like to highlight, are the ones focusing on youth, that there are higher than their heterosexual and cisgender counterparts. In the LGBTQ community, there are everybody has stress, of course, but LGBTQ plus youth have an added share of stress in their identity and being a part of the community. And so if we don't turn to mental health care, we turn to unhealthy coping mechanisms, smoking being one of them. Also, smoking, whether it's cigarettes or vapes or e-cigarettes, is a social activity. As we come together in a group, we participate in social activities, and the bar and club scene is so dominant in the queer community that, especially in the 90s, cigarettes now transitioned more to e-cigarettes and vapes. Smoking was just rampant because the bar and the club scene, it's where the queer community, I'm again not speaking for everybody, goes for sanctuary, for haven, to be seen. For some people, it's the only place that they're able to truly be themselves, is this one club that might be an hour drive from their tiny little town they live in. So smoking is definitely a factor. And no one smokes, like I said, because they think it's good for them. Nobody thinks when they smoke or do an e-cigarette that they're actually helping themselves. So I personally don't think that increased education efforts focusing on smoking are terribly effective with the community. I would suggest to try to focus on changing the culture. Back when I smoked, what would I do if I was waiting outside a bar for a friend to show up? I don't want to just stand there by myself looking like I'm waiting on a friend, so I'm going to smoke. I'm going to relieve that social anxiety and awkwardness by smoking. But there are other things you can do to not be awkward. So I think, when it comes to the queer community, looking at the culture, as well as focusing on other coping strategies and focusing on good coping strategies and focusing on true mental health care. Along with cigarettes comes alcohol. And again, I'll leave the statistics up there for you to read. And again, this ties right in with the smoking. Coping mechanism in the form of a beer or a whiskey or whatever the case may be. And it ties in, just like smoking, to the social activity and to the bar and club scene. And while I don't think that people necessarily think drinking is good for them, I really don't think they understand how bad for them it can really be. And I don't know that the connection between alcohol and cancer is always addressed. So were I to be speaking with anybody about this, my suggestion would be to increase education efforts for targeting the queer community, making that connection to really hit home that your increased alcohol consumption can affect your likelihood to get a cancer diagnosis. And I think that especially storytelling events, I know that Matthew mentioned storytelling. I think it's huge. I think storytelling is much more impactful than looking at a bunch of statistics and data. So get stories of the members of the queer community who have been impacted by alcohol as it pertains to cancer. Get them in front of groups and create awareness. Same thing also can go for the healthcare community. Have some Q&A sessions with members of the queer community who have been impacted by cancer as a result of alcohol, and get conversations going. Another risk factor is fear of discrimination. As you can see, the statistics are they talk about how 50% of the LGBTQ participants of this survey were concerned about facing discrimination in a healthcare setting. 20% were very concerned about facing discrimination, and over 50% had concerns that legislation will negatively impact their ability to receive healthcare without discrimination. And I 100% think the healthcare community, the support community, needs to be educated on the queer community. But I personally also feel that this is where the patient can really advocate for themselves when possible. And the patient's network of allies can research healthcare providers. They can get word of mouth recommendations from queer friends and peers, get word of mouth recommendations from allies. And once they found a primary care physician that they're comfortable with, they can very specifically say, if you have to refer me to a specialist, could you please make sure or do your best to make sure you're referring me to someone who's either part of the community or an ally. All of my primary care physician and all of my specialists are members of the queer community, and I have such a supportive medical network, but I would not have had that if I didn't help create it myself. I'm not saying the onus is all on the patient, but I do think this is one area where the patient can really impact their care. And for instance, Atlanta, when I was living in Atlanta is one of the gayest, friendliest cities in the United States, to the point where we used to have the gay pages, not the yellow page. Well, there were the yellow pages, but for the queer community. And it was about this thick of, business services that were all run and owned by members of the community or allies. So when I was looking for a primary care physician in Atlanta, I picked out of the gay pages, and then I went and I interviewed the primary care physician before even scheduling an appointment for a checkup, to make sure that he and I aligned, because even though he was a part of the community, as with most communities, there can be discrimination within communities against sub-communities, and I just wanted to make sure that we were on the same page. I liked what he said, and he became my primary care physician. So I highly recommend, if one is able to have those conversations before you agree to get an exam or a checkup from someone. Make sure you're comfortable with who's going to be checking you out. Then lack of equitable care. This is a big one that has also impacted my journey. You can read the stats up there for yourself about how comfortable the med students that were surveyed in this poll felt providing care for the community. The fact that I do want to highlight is the one that's down at the bottom there. Only 27% felt confident in their knowledge of transgender health needs. So it's quite a dip from where you're up at 96.3, dropping down to 27%, just feeling confident about the needs of the transgender community. Obviously, a huge area for education in the medical community. And I have definitely been impacted by this. If a ultrasound tech that I saw in early 2009 had been more either aware or comfortable with the queer community, I am confident that my cancer would have been caught at months and months earlier. It wasn't. I've also been looking through old medical records from my hospitalizations for a project I'm working on for grad school, and just the misgendering in my records. Within one report, I'm he, then I'm she, then I'm she, then I'm he. At one point, I'm a transgender woman, which I am not. And then later on, I am a transgender man, which I am, but consistency, please. It's laughable the way my records read. And again, it's just lack of awareness and the need for greater education. And after I had my diagnosis on my this sebaceous carcinoma on my eye, I was at Wills Eye Hospital in Philadelphia having surgery on my eyelid. And I was talking to one of the nurses, and somehow my uterine cancer had come up, and one of the other nurses in the room started laughing. And I was like, oh, that's a good one, uterine cancer. And I was like, I kind of just looked at him, and the other nurse said, he's not kidding, dumbass. He's like, did you not read through his chart? He's a transgender man. He had stage 3C uterine cancer. And the guy was, of course, completely apologetic. But just an example of how, proper bedside manner could be taught. It didn't stop me from getting the procedure, though, that's for sure. So educate the medical community, introduce them to members of the queer community, create connections, and hold Q&A sessions. You need to know the people you're treating in order to be able to address their needs and to make them feel comfortable.
So Austin and I wanted to end our presentation by giving everyone just some resources that we have found valuable specifically for this age demographic. I'll go over a couple. One, as you can tell in those photos right next to on the slide, there is an organization that is near and dear to my heart called Project Coro. Project Coro is open to pretty much adolescents and young adults that are cancer survivors. They can be in active treatment, however, it's typically for people that have finished treatment. Project Coro is an amazing organization in the sense of trying to learn a new skill. They have camps in different areas of the world, one being in Colorado to help cancer survivors learn how to ski or snowboard, one being in Hawaii, learning how to surf. I was very fortunate to be able to go to Maui to learn how to surf. And as you can tell, I am now a professional surfer from that camp. Based on that photo right there, that's the only time I was up on the board. I have to be completely honest there. But in the photo right above it, there was probably 12 other cancer survivors that I was able to connect with. They just opened up a camp, I think last year, in Costa Rica to learn how to surf as well there. It is an amazing organization. So if you are working with any adolescents, young adults, definitely an organization to refer them to. Another one is the SAM Fund. The SAM Fund actually has a family building grant specifically for adoption as well as IVF costs. It is a really great organization that has a family building grant. It is open every once in a while. I think it's quarterly, I'm not entirely sure. But these resources are on your AYA resource page that is probably in your folders. And then the other one that I know Matt Zachary touched briefly on is Cancer and Careers. Cancer and Careers is a really great organization to really help, help patients understand what they can do to have that conversation with their employer, as well as they also have career coaches that you can talk with that they would be able to help them get back on track. So those are some of the organizations that I had put on there. And then Austin had put on some LGBTQ plus resources as well that I'll have him briefly mention, and then we'll get into the group activity.
So here I've just put together a brief list of resources. Across the river in Highland Park, you've got the Pride Center of New Jersey. They provide support, educational tools, programs, social opportunities, and health and education resources to the queer community and to allies. There's also a wonderful program up in Parsippany. I love the Pride Center, but I am partial also to EDGE because I'm friends with people who work there. EDGE New Jersey, they offer public health services and events. They have care coordination to help clients access the appropriate resources and to help them navigate whatever journey they're on. They provide individual and family counseling, and they also have a community center for drop-in community connections. There's the Babs Sipperstein Proud Clinic, part of Robert Wood Johnson in Somerville. They provide specialized primary care services for the LGBTQ plus community, behavioral health services, as well as health education. And then there's High Tops down in Princeton, wonderful organization. They support queer youth with sex education programs, peer leadership programs. They support and are advocates for queer youth, and they run gender and sex education communities or education for adults in the community. And Trevor Project, they They have a physical space. They're out in California though, but a lot of their resources are available online, via Zoom, over the phone, and they're just an amazing organization focusing on the mental well-being of queer youth. So those are just a handful of resources if you are working with any LGBTQ plus patients, clients, etc., and you need some resources, they're there for you.